Now we'll deal with the second segment of the video, which is management of infertility. Like I said earlier, there are four important components that are required for pregnancy. One is the tubal factor, the male factor, the ovulation factor, and what I'll call the coital factor, timing of sex. And the management of infertility have to deal with all these items one by one. 80% of women who cannot get pregnant is because both tubes are blocked. And what blocked the tubes? An infection a woman may have had many years ago. Most commonly, sexually transmitted infection, which starts in the vagina. If it's not treated, it goes upstairs into the womb, from the womb into the tubes. It either narrows down the tube or blocks them completely. So the most important thing for a woman is to check if the tubes are open. The commonest test we use is the HSG, called hysterosalpingogram. It's done by an radiologist, an X-ray. They inject a dye, which will show the womb and show the tubes, or one tube or no tube at all. If the test shows that both tubes are open, we accept it. If it shows that the tubes are blocked, we don't, because there's a superior test. We know that about 10-15% of cases, the tubes may not be blocked, even though they show that they are blocked on HSG, because the test is a bit uncomfortable and the tubes can go into spasm because of the pain, and the dye may not pass. So for such women, we recommend a more superior test called laparoscopy and dye test. This involves going to theater, being put to sleep, and we'll put a small telescope through your belly button, and then the same dye is injected, but this time the woman is sleeping. So there's no pain element and there'll be no spasm of tubes. So that allows the doctor to eyeball the organs in the abdomen using the telescope. It shows on a screen, television screen, and you can see the dye going through the tubes. And if the tubes are blocked, you can see why they are blocked. So we only recommend this laparoscopy and dye test when the HSG shows that the tubes are blocked, both tubes. If it shows that one tube is okay, you don't have to bother about the second tube, because a woman only gets pregnant from one side. And it just means you don't have a spare. About 30% of women in our society have only one open tube, and they're doing well enough with it, having babies. So don't go to investigate or treat one blocked tube if one is open. That's all you need for pregnancy. And if the tubes are blocked in a woman, in the past we did surgery trying to open the tube, but we find that those surgeries are usually, they fail. They take 3-4 hours, you think you open the tube, but the disease has already affected the muscles of the tube. So it might appear open at surgery, but later on they get blocked. So we recommend assisted reproductive technology for such women. That's what you call the test tube baby. What happens that what should happen in the tube is meant to happen in the lab. The woman is given injections to produce many eggs. Before ovulation, the eggs are aspirated, and then the man's sperm is brought and they're mixed outside in the lab. And after fertilization, the pregnancy now injected back into the womb. It's expensive, but it's better than going to do surgery. It might take a few months. If you know what it is, you plan for it. Unfortunately, IVF or test tube baby does not guarantee pregnancy. Only about 30% will get pregnant at once. So it might take you 2 or 3 trials, and each trial costs $1 million or 2 or more, depending on where you're doing it. So you must have a lot of money. But embarking on surgery to raise false hopes, I will not recommend. The next important test is a man's sperm test. We call semen analysis. The semen is obtained, you give it to a lab. It's a very simple test to do. Under a microscope, they can count the sperm and make a projection, how many sperm you have, and the speed of the sperm. The average man produces between 20 to 100 million sperm each time he has contact with a woman. And then the speed, we expect at least half of them to be fast, because the faster they are, the faster they get to the tube. Half of it will pour out when a woman gets up. There's a lot of wastage in the man because the sperm is inexhaustible. Unlike a woman who is born with a fixed number of eggs, a man's sperm is produced from a stem cell. So even if a man of 100 is still producing sperm, while a woman's egg can finish much earlier in life because she's not born with enough sperm, enough eggs in the tube, enough eggs in the ovary. So a man's sperm should be checked, do the total count, do the speed, and do the morphology. How many of them are normal? The simple test. That's the male factor. If the man's sperm is, it may not be up to 20 million. Even I found out there are men with 5 million who got a woman pregnant. What I tend to advise people like that is sperm is being produced every day. So I advise abstinence before the 2 days of ovulation. So if ovulation will be Saturday and Sunday by calculation, then Wednesday, Thursday, Friday, you don't meet. Then you have a higher concentration of sperm with higher speed. That helps. So even though the book say 20 million, there are people with 5 million. If the sperm is fast enough, can still get a woman pregnant. But if at the end of the day, after 6 months, nothing has happened, then you can refer them to, you refer the man to a urologist. A urologist is equivalent to a gynecologist for women. It's the gynecologist for the man. He looks after the male reproductive function. Then he'll be able to advise on what to do. The next thing is the ovulation factor. A woman should ovulate every month. Regular menses more or less means you are ovulating every month. So if you don't see your menses every month, it means you're not ovulating regularly. The first thing is to check how many eggs in the ovary, what you call ovarian reserve. We do a test that will show us indirectly how many eggs you have there. The commonest factor we have that causes problem with women, one of the commonest factors is what you call polycystic ovary syndrome, where there are eggs in the ovary but they are not being released. There's a treatment we use for that. We use metformin, a drug we use for diabetes and clomid. But you need to confirm. You do a special ultrasound scan done by people who are well trained, because the average sonographer may not notice PCOS, as we call it. So the doctor should refer you to a very qualified or reputable ultrasound facility where they will do that. And if it's confirmed, the treatment we can give you, but the doctor will explain to you how it works. But that's the second thing. And in some other cases, there are other problems. You can use drugs like clomiphene to make you stimulate the ovary, make you ovulate. But don't take these drugs yourself. Go and see the doctor, because all the other factors must be there. So you deal with the ovulation factor. Then the next thing is the timing factor. Always, the doctor should always ask you, is your husband in the same town as yourself? Or is he living in another town? If he's living in another town, you work out the ovulation dates at the beginning of the menses. So an ovulation will occur 12 days later. Then the woman must have to go and travel and meet the husband. Or they'll meet halfway. Because if they never meet during those 2 days, he will never get pregnant. Even that 25% chance of per month will not be there. But this is a factor people tend to forget. So that separation factor is very important. So you have to deal with the 4 factors: the tubal factor, the male factor, the ovulation factor, and the timing of sex factor. These things are very important. And if all these things fail, if a woman has been fully investigated and everything is okay, what I normally do with my patients is that I see them every month. I calculate ovulation for them based on the cycle, because cycle varies every month. And ovulation occurs 14 days before the next period. Seeing them every month also provides psychological support. The woman knows that somebody is caring for her, and it makes a difference. 80% will get pregnant within 6 months. But if they don't get pregnant, then you sit down with them again and review the management. That's how it's done. And I found this method, this approach, very useful. My patients communicate with me. Those in town visit the hospital. Those who are not in town communicate with me. So this is the way we manage infertility in women, dealing with all the 4 factors. I hope you've liked the video. If you have any questions or any comments, please make them, and I'll try and reply to them at some point in the next week or 2.